Assalamu alaikum. Today's lecture is intra-aortic balloon pump, part of a real case discussion. And I received many questions regarding a patient who has intra-aortic balloon pump. He is hypotensive. What we should do, what the cause, how can we treat. So in this lecture, I will try to summarize this is troubleshooting in a systematic approach. The 67 years old male with a history of anterior STEMI. He has recent BCI to LAD and he is on the aortic balloon pump support in ICU. On day 2, he became hypotensive. Mean arterial blood pressure less than 860 mm mercury. He is tachycardic 110 and he oliguric. On his assessment, we found the arterial waveform show loss of augmentation, no sign of balloon rupture, echo showing a reduced left ventricular ejection fraction, it's about 15%, and moderate RV dysfunction. The lactate level 4.2 millimole, and there is no sign of infection. What are steps taken? First, we should check the console, confirming suboptimal timing should be corrected. And as we mentioned before, we should go for the console for 2T, timing and trigger. Starting inotropic support if the patient not on inotropic support, or escalating the inotropic support. If we have facility to insert pulmonary artery cast, we should insert and see if there is high CVB, if there is low cardiac index, or we can escalate for Impella or ECMO support for cardiac output. What are causes of patient who had intra-aortic balloon pump and he is still hypotensive? First, maybe the patient has left ventricle outflow tract obstruction. As we know, intra-aortic balloon can reduce after load, can unmask left ventricle outflow obstruction, or can worsening the dynamic obstruction, especially if the patient has a hypercontractile anteroseptal wall in posterior inferior myocardial infarction. Sometimes the patient will have SAM or systolic anterior motion of mitral valve, which can aggravate this obstruction and hypotension. The second cause is hypovolemia. The patient has insufficient preload, which limit effectiveness of intra-aortic balloon pump, reducing cardiac output, lead to more hypotension or decrease in systemic vascular resistance. Vasoplegia and peripheral vasodilatation. Profound vasodilatation may be due to sepsis, can lead to hypotension, which will not respond to intra-aortic balloon pump support. And then another cause is like device malfunction, malposition, and this is we described in troubleshooting lecture. Arrhythmias, rapid arrhythmia, tachyarrhythmias can reduce effectiveness of intra-aortic balloon pump by not allowing adequate balloon inflation or deflation cycles. Right ventricular failure, intra-aortic balloon doesn't support the RV. Isolated or combined RV failure can lead to inadequate LV preload or systemic hypotension. Also, severe left ventricular failure, as it happened for severe reduction in ejection fraction or cardiac output. As intra-aortic balloon pump to work, should be pulse. There is at least 1.5 cardiac index or stroke volume 33. Less than that, intra-aortic balloon pump cannot support cardiac output. The only support the balloon give is 15%. When it comes for evaluation steps, clinical assessment, we should assess for new murmurs suggested of left ventricle outflow tract obstruction, cold extremities, urinary output, other signs of low perfusion. Hemodynamic monitoring, using arterial waveform analysis, if available, pulmonary artery cast to assess preload, afterload, cardiac output, and lactate level. Imaging is very important to rule out dynamic left ventricle outflow obstruction or any mechanical complication to be treated or referred to cardiac surgery. Then fourth step is to check the correct inflation, deflation timing relative to the cardiac cycle, ECG to identify arrhythmias, labs like CBC, lactate, troponin, renal function, blood cultures to see if the infection is suspected or not. Management strategy: patient have dynamic left ventricular obstruction, outflow obstruction, so reduction or stopping inotropes as we can, giving fluid, reduction in the intra-aortic balloon pump augmentation, starting beta blocker if not contraindicated. If the patient is hypovolemic, we can give IV fluid to restore the preload. Patient vasoplegia, we can use alpha agonist vasopressors. If we have device issue like timing, position, function, so all of these should be corrected, troubleshooting. Arrhythmia should be treated to restore the effective cardiac rhythm. I made small algorithm for intra-aortic balloon pump. So I will start from if the patient have low mean arterial blood pressure less than 65 and there is sign of hyperperfusion. If yes, so we can go check the timing and the triggers, inflation. If the aortic balloon pump for working normally, it's yes. So immediate bedside workup for echo, left ventricle and RV function, valves, lactate, and ECG labs. And if we identify the cause, if it's a mechanical, consult surgery, and arrhythmias, we can cardiovert the patient. And if septic shock, we start antibiotic and vasopressor, hypovolemia, fluid challenge, and cardiogenic shock start or increase inotropic support. And if there is persistent shock, if it's yes, escalate the support for LV to Impella. If we have our failure, we can go for VA ECMO. If there is no persistent of the shock, we can wean and monitor intra-aortic balloon pump. And we should evaluate the patient every 2 hours, 2 to 4 hours, repeat the echo and trending the lactate and adjusting the support. Also EBG and VBG post troubleshooting is very important. It's very important for left ventricle outflow tract obstruction to have early echo evaluation to diagnose the hypotension if developed after intra-aortic balloon replacement. Also, reduction of intra-aortic balloon pump augmentation from 1 to 1 to 1 to 3 is important. Careful volume administration will rapidly improving the dynamics, hemodynamics in patient who has LVO2, LVOT obstruction. Also, beta blocker is a beneficial in selected cases with the dynamic left ventricle outflow obstruction, provided there is no contraindication. So if we know and target the intervention, it's very important to improving outcome in patient hypotensive with intra-aortic balloon pump support. These is our references of the lecture. For questions, you can put comments and question down. Thank you for your listening.